are areas where we have limited number of population. So getting specialist, super specialist or subspecialist to those areas is uh, not feasible and not practical also. So in that case, telemedicine can help a lot. And the subspecialist, as we family physicians, we always say that 90 up to 95% of the cases can be managed by a qualified, trained family physician. At the same time, we need other specialists or subspecialists to take care of the remaining 10. So one thing is that the trained family physicians are not there. Most of the people who work in the rural or difficult areas are MBBS or just medical graduates. So they would, for them, maybe a much higher percentage of the patients should be referred to a specialist or a subspecialist. In that case, telemedicine has helped, and it's helping, and in the future it will play a much bigger role. And we have seen so many success stories in from rural areas. So both in private sectors and in government sectors as well. So the primary care physician can provide and refer or give a teleconsult to those particular specialist or subspecialist, and in only in um, specific cases we need to transport the patient. So money is saved, time is saved, and resources are saved. So that is the future for a country like India, I guess.
Thank you, Sarin sir. Just a few inputs from Hemant Saluja sir on the same point. Any point that you would?
Thank you, Dr. Vidyut. Yeah, I was just those Dr. Seren has almost covered the entire spectrum of telemedicine. However, I would like to add that like every cloud has a silver lining. So the cloud of COVID pandemic had its silver lining in terms of the irreversible availability of telemedicine. And the Indian government and the Indian healthcare providers were very quick to respond. On March 22nd, if I remember correctly, the lockdown was in 2020, the lockdown was started. And on March 25, 2020, Indian Ministry of Health and Family Welfare had come out with the telemedicine guidelines for the first time in India. And telemedicine was made available to the remotest corner of India where we had telephone connections available. And anybody with a smartphone could connect, or with a computer could connect to the healthcare provider with the help of telemedicine. And along with that, the government of India started the national telemedicine service called the eSanjeevani, which is free for all, accessible to one and all, irrespective of where they are located, in rural or in urban areas, whether they are rich or they are poor, and they have access to not just the primary care physician, but also the various specialists of various basic specialties. And the timings are from 9:30 in the morning to about 6 p.m. with a break of 2 to 3 p.m. on all Monday to Friday, and 7:30 to 2 p.m. on Saturdays, Sunday being off. But you have to take a online appointment first, and though there are some provisions for walk-ins for immediate access also, depending upon the area and the kind of specialty that you want to log in. So this service has been is running free of cost at various conducted by the various local authorities very successfully. And it is called eSanjeevani. It is the National Telemedicine Service of India. And definitely there have been private players were fast to respond to and to provide healthcare in the fast emerging scenario of COVID and the aftermath of that disease. And even now, sometimes follow-up is for people coming from remote places because of various personal and logistic circumstances. A follow-up visit is usually being done, not uncommonly being done by telemedicine. So telemedicine itself has changed the way form in which healthcare is being rolled out now.
Thank you so much, sir. Really great inputs, and it feels really great, you know, as growing up. Always we had friends and everyone around us who used to crib about हमारा tax का पैसा कहाँ जा रहा है, कहाँ जा रहा है. Now we know what all efforts the government is you know, taking towards promoting health, and how these services are reaching people, like you said, for follow-up visits, which patients find inconvenient several times. Not uncommon that teleconsult is being done for that. Thank you so much, sir, for that.
I would like to add, it is not just for follow-up, it is also for asking trivial queries like this brand is not available, you know, can I substitute? Maybe I'm having some problem. So the person or the patient or the family does not have to spend money in coming to the center or to access the doctor. They can just, you know, through an appointment, they can
So just continuing with this question only because I think both Hemant Saluja sir and Saran sir closed their comments on telemedicine, mentioning about how this has made healthcare more affordable. So coming to the question of affordability, are we really providing the best of healthcare at the cheapest available rates? Sarin sir, your comments on the topic to begin with.
I would say this is a very tricky question, and I think there is no straightforward answer to that. Are we providing affordable healthcare? Yes, we are trying to provide the best affordable healthcare, especially in the government sector. I can be very much sure about that. But there are some other concerns. Many times we discuss many things. Many things we discuss about the affordability. Why are we giving too many antibiotics? Are we doing testing? Are we prescribing lab investigations which are not backed by the evidence? So as clinicians, as family physicians, we are supposed to have we are supposed to follow evidence-based medicine, and many a times that itself will make the treatment affordable, much affordable. But the thing is that in India, one good thing is we have that turnaround time is very less. The time to symptom onset to the first diagnosis is much shorter than many of the Western countries or other countries. This itself creates a huge pressure on the treating physician, and they are forced to get the diagnosis as early as possible. And this is of particular importance in the private sector. So whenever the patient comes, they want the diagnosis. Even with, we all as clinicians, we all know that most of the infectious diseases, many of these metabolic syndromes, they have a typical the infectious disease. Most of the infectious diseases have a similar presentation, like fever, myalgia, fatigue, headache, non-specific aches and pain, decreased appetite. All these are same for many of the infectious diseases. So as clinicians, we try to find out the red flag signs, and especially as family physicians, we try to treat the patient rather than the disease. But sad to say, with the more accessibility, people tend to get a quicker treatment. So that will bring that will force, I would say that will force the physician to go for unnecessary treatments, early prescription of antibiotics, and thus the treatment, though we are trying to provide affordable, ethical treatment, unfortunately in many times it becomes very expensive. And many studies have proven that unnecessary prescription of medicines, investigations will lead to further complications, and that will increase the out of pocket expenditure. So and especially when we have to travel for a longer distance for treatment, like my Hemant sir already mentioned, they have to travel to 100 kilometers, 50 kilometers to get their treatment follow up, or to get their query done. Then in that time, what they consider, the patient is more worried about their out of pocket expenditure for the travel. They may not be focused on the entire health system or entire health outcome, or how the disease will progress. So they want antibiotics, they want treatment. Most of the even when the patient is not in a position to afford all these expensive tests and all, they themselves may be get ready to do all these things. So ultimately this will not bring any good, though the patient for the time being they might think that they are getting a better care. So that will actually decreases the affordability. And especially this is applicable for rural areas. And in urban areas, there is a huge competition is there, especially between the private players. So they too want to get the quicker relief to the patient. So in that sense also, there is in many of the places there is an unhealthy competition, which increases the out of pocket expenditure. So but government and all the private players, they have the fixed policy to cut down, to avoid unnecessary investigations and unnecessary prescription of antibiotics and other unethical medications. I think in the past we have come a long way forward on behalf of this antibiotic prescription, but I don't think we have gone that far for lab investigations and other invasive investigations.
That's it. Point well taken. Cost-effective treatment is what we are discussing, and like Dr. Sarin rightly said, that we are treating the patient and not the disease. And as health is a shared responsibility between the patient and the caregiver, both the ends probably need to understand this, that there are no shorter cuts or quicker cuts into getting adequate health care. But obviously with logistic issues, many of the patients, like you rightly pointed out, sir, that they opt for quicker means of probably symptom relief, which like leads to greater cost to the pocket. But Hemant sir,
And before that, can I add 2 more points? One step in the right direction towards cutting or making the treatment more affordable is telemedicine. Second one is making medicines in the generic form. So again, there are generic medicines which can be purchased at a much cheaper level, but I'm not that sure. I'm not that confident about the quality of all medications which are available in our market. So I had a chance to discuss with the state and national authorities regarding the quality issue of these many generic medications. So what they what they said was like, in the beginning they have, whenever they have a quality check, whenever they do a quality check, they get the best medicines. But the system to follow up each and every batch, that's especially in a country like India, it's immense, it's very expensive. And as of now we don't have that much manpower or resources to spend on uh, spend to check all batches which are provided by the drug company. So that there is a huge lacuna is there. So we have to find a way to fight against these drawbacks. So over to you, sir.
Yeah. So, Serin, those are all, to my mind, to my understanding, the whatever you stated is an operational challenge that
Yes.
the entire system is probably gearing up to overcome. But having said that, it is definitely worth applauding that India has, for the first time, started what is called the Jan Aushadhi stores, which is a very, very affordable where point of sale of generic, good quality, genuine medicines. And these are all made available to the public in general by the supplier. And they are very good quality drugs. That is what the agencies and authorities assure. And I have no reason to disbelieve that, because it is better than patient not having healthcare. Whatever obstacles or operational challenges exist of regarding doubts on quality, that can be set aside. That can definitely be checks and measures can be put in, checks and balances can be put in to see that to assure and reflect that the qualities have been checked. However, that should not come in the way of healthcare delivery. That should not come in the way of access to healthcare, because right to health is not just healthcare. Right to health is more than just healthcare. It is also the determinants, access to the determinants of health, improvements in the determinants, that is access, affordability, that is quality, that is socio-economic circumstances. So right to health is much beyond just healthcare across all ages. And we see that the entire healthcare system in India, be it government, or be it public, or be it private, it's all gearing up and moving towards that, providing good quality, affordable, acceptable healthcare to as far as possible to all people who can come in the fold of healthcare. So yes, and in out-of-pocket expenses have been not been the lowest in India, in the world, but however, the cost of treatment as compared to the cost of treatment in developed countries and in the West is almost, if I may not be over exaggerating, it would only be about 50% of their costs. So cost of treatment as compared to the treatment in the developed world is much less, but yes, out-of-pocket expenses in India on healthcare can have a tremendous way to go down. I mean, there are and right actions and steps are being taken to control the out-of-pocket expenses. It's only for the time for us to achieve those objectives. It might be a long journey, but yes, we are all striving towards that, because the government has started increasing the health budget from 1.5% to almost 1.98% of GDP. And all that is going towards digitization, towards increasing the healthcare infrastructure, towards capacity building, towards, and today itself, you must have read in one of the leading national dailies that the All India Institute of Medical Sciences has publicly said that the way to go forward is to improve the primary healthcare system in India. It was in the Times of India today, and I'm sure it must be there in all other dailies as well. But so that goes, that further reiterates the importance of the primary building up capacity in the primary healthcare sector of India. So having said that, yes, healthcare in India is cheap as compared to West, but out-of-pocket expenses are far more than what one would have desired.
Any comments, sir? How dealing with the logistical issues, barring let's say practicing telemedicine, how probably we can convince the patients to not take quicker or shorter cuts, get early investigations done just to kind of satisfy their belief, because let's say in my practice I see a lot of Vidal being done on, let's say, the first day of fever itself or the second day of fever, and by third day, let's say, antibiotics being started. I get the vibe from the expression already, but that's just a question. Like, how can we kind of convince the patients to not fall for early quick investigations just for the sake of it?
So to my mind, whatever you have said, let's not discuss specifics, but yes, by empowering the healthcare seeker with the available modalities of healthcare that he has access to. Now, even though the National Telemedicine Service has been started, but probably not many people are aware of it. It has been
Okay.
started for more than 2 years now, but not many people are aware of it. Now, it is for us and for similar-minded people to convince and to disseminate the information that yes, there exists services like this for which you don't even have to pay. Tell me a country where, in spite of the kind of vast geographical extent that we have, and the variation in population densities, and the variation in the size of pocket one has, and the affordability of each other, that healthcare is being provided, not just primary healthcare, even specialized healthcare is being provided free of cost at their own doorstep, at their own convenience, by the National Telemedicine Service. So it's a wonderful thing for everybody to spread the awareness about. And yes, once the consumer or the client is empowered with information and knowledge that yes, these are things that should be done, and these are things that one has access to, definitely the quality of healthcare will become more scientific rather than empirical.
Thank you so much, sir. So coming to our next question, we discussed a lot about how the government is trying to subsidize and provide cost-effective healthcare. But what would you suggest is the role of the private players in healthcare in the backdrop of insurance support to decrease the cost burden of healthcare on the patient?
Okay. So now these days, previously only inpatient services or hospitals or institutions were being accredited or empaneled by the insurance providers. But now we see some of the private insurance players empaneling registered practitioners and their OPDs and offices for OPD reimbursements also. So this is a good step, and it will go a long way in curtailing out-of-pocket expense. And because it is an institutionalized patronizing of the office practice or the primary care, so the inpatients or the admissions and their expenses will kind of, as from where I see, will kind of come down in the times to come. And this is a the private players are have changed their mindset and their understanding of the changing healthcare scenario in India, and are acting towards devising out of the box solutions for providing primary healthcare, which is scientific and which is non-empirical. So yes, the private players have a role to play in it, as you asked, and even I think even the medical associations and the professional bodies are are thinking about what they can do to impress upon the government to change the rules accordingly, so that more and more primary care becomes reimbursable by the governmental healthcare insurance agencies also.
Thank you, sir. Thank you so much. Sarin sir, your comments on the same.
Uh, uh, um, this the sorry the if to say about the private uh, private health insurance schemes and all, then there is a huge disparity between the premium or the charges the patient has to bear. So there is I don't think that there is a standardization of such expenses or such premium uh, for any insurance. So that's a very gray area, and uh, we doctors as a community we should uh, work towards uh, framing such or we should help the government to framing policies to have a better understanding, better clarity on the insurance policies and the premium uh, the the premium packages, the premium for the packages for any health delivery through healthcare delivery through insurance policies. And yeah, that's it. I think most of the things are already covered by Hemant sir. Dr. Vidyut, you are on mute.
Hello. Yeah. Just out of personal query, from what I gather from my friends practicing in Kerala, like they say that most of even geriatric and palliative care, all of that is being provided very effectively by government facilities. For example, even in not very urban areas, even in rural areas, it is being provided. So, does this increase the efficacy, or let's say does it lead to a competitive pricing by private players, so that they kind of decrease their costs of caregiving, so that even their facilities are accessed, and does that benefit the patient ultimately?
So, are you asking specifically about Kerala?
Yes, yes, specifically about Kerala, because yes, this is the model that we have noticed is way better in Kerala government.
Yeah.
Yes.
So yeah, your I think your perception about that health system, how the health system works in Kerala is correct only. So we have in Kerala we have around 1,000 local self-government bodies, and each and every self government body has at least one primary health center. Now those are changed to family health center. So there you will get primary health care at no cost. So you have to pay only the it's not charge, actually it's a donation to the hospital management committee for the upkeeping of the extra facilities that is provided by the provided by that particular health facility or family health center. So other than that, everything is free. Consultation is free. Medicines are free. Investigations are free. In some places, you have to pay very minimal charges for the investigation. So all the primary and all the primary level healthcare facilities are provided free of cost. Absolutely no cost to the patient. Now coming to the secondary and tertiary level, then there also the treatment is free, but the thing is not all the medicines are available in the the government pharmacy, or you have to depend at the outside labs for some particular investigations. So in those in those scenarios, you have some amount you have to spend some amount from your pocket. Other than that, that entire treatment is free. Now coming to private hospital, why people then why people prefer some people prefer private hospital? Why is that? If good quality care is available at free of cost, the thing is so the COVID was a game changer. Before that, around 30 only 30% of the public depend on government health sectors, and the majority of the public went to private sector. Now COVID has changed that. Now most of the many of the patients go to government sector, so they have a belief in that government system. They have that trust. They are very much sure that they will get good quality care. But again there are few concerns, like if you are going to a government hospital, there will be at least 100 or 200 people waiting in that queue. You have to wait there patiently. You have to wait for your turn. Number one. Second thing, time is limited. So most of the places have limited time. So 8 to 1, 8 to 3, 8 to 4. So you have to most of the people will be working. They don't want to spend one day earning for seeing a doctor. So they want flexibility in seeing doctors. The third thing, many people have, as we already discussed, they have health packages. So they prefer private hospitals based on their the health and financial planning. Another thing, for specialists and all, if they want to
Dr. Sarin, your voice is getting disrupted a bit.
Am I audible now?
Yeah. Yes.
Yeah. Now those who are consulting as subspecialist or a specialist, they have to go to a medical college or a district hospital, and they have to spend an entire day there. So for many people, that is a major concern, and they prefer to go to private hospitals, where they might get the benefits of insurance and all. So when as you rightly pointed out, so when the private players see that the good quality care is given by the government at no cost, they have to be in that in the game of health care. They have to be the best. So they have to give it good quality care. They have to give the affordable care, and they have to provide in such a way that people, those who are going to government hospitals, should divert themselves to the private hospitals. Did I answer your question?
Yeah. Yes. Thank you so much.
So one more point though. So thus the overall treatment cost comes down.
Understood. Absolutely. Coming to our last question, as we see medical tourism rising, what future do we think that it holds for young family physicians in strengthening the vision of my health, my right? I would like to get Hemant sir's comment first on this.
Well, I would request, thank you very much for asking me that, Vidyut. I think there are some participants who have inevitably forgotten to mute their mics, and so I would request them to mute the mics because some of the sounds are probably distracting. So the question is that in this light of medical tourism coming, what the role of young primary care in view of my health, my right. So medical tourism is a reality. As I said, treatment in India is 50%, about 50%, half the cost of the treatment in developed world, and we are fast approaching becoming developed. And with the health policies in force and the rolling out of other capacity building measures, I think it should not be far from now that India is counted as one of the developed countries. But till the time we achieve that, there is going to be a shift of medical tourism from tier A cities to tier B cities, because the tier 2 cities are also, the healthcare institutes are also gearing up for medical tourism, providing a even further more affordable option of the similar treatment as in tier 1 cities. And some medical tourism is being directed and attracted by those cities other than the metros. So the entire healthcare infrastructure of tier 1, tier 2 is geared up or is gearing up for embracing and accommodating the influx of medical tourism that brings with itself foreign exchange. At the same time, also acts as an impetus for the healthcare providers to improve their facilities. Now, once the healthcare provider rolls out a service to the medical tourist, the tourist goes back after a period of time to his native country and needs follow-up. So what do they do? Do they come back? No, they use telemedicine. And once this healthcare provider is busy, so who handles? The empowered person in the team, that is either or an associate who's acting out of office to take care of certain not so critical professionally subject matter demanding questions about the healthcare of previously treated patients. So the primary care physician rises to the occasion and fills the gap that exists here. And they do it, and they also take care of the they act as a professional gatekeeper for all those coming from within the country and from outside, to divert them appropriately as and when required, if required, to the concerned specialist if the problem or the challenge they are facing cannot be dealt with by the primary care healthcare provider. So definitely the primary care physician has a lot of role to play in the upcoming years and decades, till India and healthcare becomes equitable, accessible, and affordable universally. And the other countries try to bring down their costs and try to bring down their turnaround time from symptoms to diagnosis, as we have in India. But I don't see that happening in the near future for other countries. But India will definitely, I see that improving in India, even beyond what is there in present day.
Thank you so much, sir. Thank you. Dr. Sarin, sir, your comments on how you think medical tourism holds future for the young family physician in strengthening the vision of my health, my right.
Yeah, I would like to agree with Hemant sir because what sir just told, and I'm already experiencing that. So we have some hospitals here in my town, and they have this kind of tourists from other countries. So why they prefer? It's much cheaper, much accessible, and once they finish treatment, they prefer to roam around in India. So it's like a package. It's a proper treatment, and they have a good time in India's tourist also. So and I would like to highlight another point. We have some family physicians who are working as such part of such teams in such hospitals. So that's wonderful. We have more openings and more opportunities for our young budding family physicians, and this is something actually so one only and we are trying to bring down the affordability. So there is a drawback to that. So when we try to bring down the affordability, the labor charges, the remuneration to the doctor will also come down. That is also happening in Kerala. I think Kerala is having one of the cheapest remuneration packages for doctors in India. So at the same time, these kind of extra opportunities for doctors will compensate that thing. So that provides a bridge between uh, our expectations and the reality. So in that sense also, it's a critical thing. And like earlier we started exporting softwares. Now we are exporting, not exporting, we are bringing patients from other countries, and we are utilizing our resources to give better healthcare, not just to our citizens, but the citizens of other nations as well.
Thank you, Dr. Sarin. I would want to take a few comments from our guest, Dr. Mohan Kubendra sir. Sir, regarding these few points, like how do you think telemedicine has been a game changer, and how private players are bringing down the cost burden and making treatment affordable, and how medical tourism is probably helping the young family physician in spending the vision of my health, my right. Mohan Kubendra sir.
Thank you, Vidit. I think we really had a very insightful discussion from the speakers. It's really uh, knowledgeable, and it's a learning opportunity for me to listen to these speakers. Today's discussion has shed the light on the challenges and opportunities in ensuring health as a fundamental right for every individual, not only in India, but from people from outside. That's what Dr. Sarin has brought up. So I feel we address two major issues when it comes to health as a fundamental right. Accessibility and affordability are the two major issues. And the speakers have very well brought out how the accessibility to healthcare in India is improved over the years, especially since COVID time. Dr. Hemant brought out a very valid point that uh, that we have achieved the WHO standard of doctor population ratio. So 1:1000. I think he was saying that we still are falling short, but I think we have achieved the doctor population ratio. So when it comes to accessibility, I think as Dr. Sarin rightly brought out, there still is a urban-rural divide, and urban-rural gap is there. But I feel now the kind of the way the urbanization is happening in India, I think there's a rapid urbanization happening. Just few years back, we had only 30% urbans versus 70%. I think now we are at 50-50. So the way it is going, probably this gap is going to be narrowed. So accessibility, and also the government has taken adequate steps to ensure that the healthcare, at least the primary healthcare, is accessible to even the remotest part of India. And when it comes to affordability, yes, see, the affordability as far as primary care was concerned was not an issue earlier also, and now also it is not an issue. It is basically the secondary care, the specialist care, and the subspecialist care where the affordability was an issue. So the government, the policies now has to a great extent, I feel has addressed that also. We have the one of the largest government-funded insurance scheme in our country, covering almost 30 crore people, which is one of the largest, the very largest insurance thing. So, and which is covering about 5 lakhs per family. I think this has made a big difference. Now I see most people, even from the rural areas, coming to the private hospitals and availing this insurance facilities. So otherwise, this was mostly out of the pocket expenditure for them, and we have seen many families selling their properties and all to get this care. So I think both affordability and accessibility has been addressed adequately. And as I already said in my opening remarks, that COVID has played a major role as a major catalyst. And post-COVID, things have improved tremendously. It has improved globally, but I think India, I think we have done exceedingly well, and I think we must uh, appreciate and be thankful to our government for this. So, while we acknowledge that there are hurdles, there are challenges, being a very large country, a diverse country, with diverse culture. But I think it's time that we should take inspiration from the progress we have made, and I think we all should make a collective resolve to strive towards a bright future as far as health is concerned, where every Indian can truly say that my health, my right, that is to be realized. I will not go into the health tourism, and I think these things have been adequately covered by uh, the speakers. What I can say is that the Kerala model, Dr. Sarin, this is really a role model state as far as the healthcare delivery is concerned. But I am seeing the changes in other states as well. So whatever Dr. Sarin brought out, like people are now going to the government hospitals and the government primary care health centers for their healthcare needs. Although, as he rightly brought out, there are challenges of time and all those constraints, but I think the health landscape has evolved and it has changed for good, at least in the urban and semi-urban areas, and even in the rural areas, I think we will see the change. But what I want to say is that let us not always depend upon the governments to achieve our good health. As individuals, as responsible citizens, I think we also have to be responsible for our health. Okay? There's an alarming rise of the lifestyle diseases, non-communicable diseases, chronic diseases, cancers, which cannot just be attributed to failure of the policymakers or the governments. We cannot. It is our responsibility. So I think every right, I think, comes with responsibility. If you say that health is a right, it is our responsibility also. Today, when we raise the slogan, yes, my health, my right, let us also take the responsibility of our own health. And I think we should also add this slogan, my health, my responsibility. Thank you. Thank you for the opportunity.
Thank you so much, sir. Really great, insightful points. We have among our guests today Dr. Sonam. So we would like to have some inputs from our other guests also. Dr. Sonam, if you would want to give some inputs.
Hello, good afternoon to you all. Access to health in Bhutan it is very much accessible in the town, in the districts, even to the remote areas. Because you all know, in Bhutan we have a free health system, consultation, medication, operation, even up to the extent of referring to outside the country. The healthcare is free. Coming to telemedicine, I think we are still yet to pick up on this telemedicine. We had started actually many years back. Somehow we are not able to continue this, and still it is a problem regarding telemedicine. But on accessibility, affordability, that's very much there, and probably I would say the best in compared to many countries. Thank you for the opportunity.
Thank you so much, Dr. Sonu. So that brings us to the end of today's session, and we had a really insightful and a really extensive discussion on all the points, and some great points that were highlighted is that how awareness through dissemination of information needs to be practiced, so that we are probably only targeting cost by investigation and treatment, but because of lack of awareness also there is a huge cost burden that can also be addressed. And with every answer I feel that the role of the family physician or the young family doctor resonates even stronger. I mean, into scientific practice and into building up a rapport with not only the patient but the entire family is what family physicians are known for. And who better than the family physician to disseminate awareness and reach out to the family to attend to the queries that probably some established subspecialists might feel is very trivial for them to answer, or because maybe they are inaccessible. So I think the role of the family physician I see only gets stronger by the day, uh, be it through in medical tourism or in awareness or giving care to the patient at hospital and as well as at the community level. So I think it was a great session, and I would really take this opportunity to thank our speakers, Dr. Hemant Saluja sir and Dr. Serin sir, and also Dr. Mohan Kuvendra sir for giving their time on a Sunday afternoon. Thank you so much, sir. And with that, we would like to bring this meeting to an end. It was a great interaction. Thank you. Thank you so much.
Thank you. Thank you so much.
Thank you.
Thank you, everyone. We'll be wrapping up the session now. Thank you for taking out time today. Yeah.